coming back to our main topic, why are we extracting the teeth? So there are some reasons for this. Most important reason is where the teeth are damaged by decay of trauma. Also, a very important situation where we do orthodontics or for different impacted teeth. Also, for the recent teeth, we have some functional problems when we are talking about interferences or contacts on the functional movements, and also for the temporary teeth. But our main interest in nowadays dentistry, especially when we are talking about implant dentistry, we need to extract this for our future implant planning in a minimally invasive way. And now I'm going to show you some of our cases and the concept that we are using when we are thinking about extracting teeth, planning for implant placement, and respecting the biological approaches. So we will go through the importance of minimally invasive approach in the implant dentistry, some words about the biology in implant placement, also, how are we preserving the 3D architecture with these minimal invasive extractions and also the flapless implant insertion? And the treatments, how are we using the digital approach today and how we went from the analog approach to the digital approach? And also the fact that we are using soft tissue level implants, and I'm going to show the advantages of using this type of implants regardless in the aesthetic zone or in the lateral zone. And also how we do it now after almost 3 years since we started using the digital concept in our approach. So a few words about the minimally invasive approach. Everybody remembers how we used to do even one single implant more than, I don't know, 12, 14 years ago. So we raised a flap, either a bigger flap sometime or a small flap. We decided like 14 years ago that we need to think about avoiding this strategy. So we started using and implementing in our office the flapless approach. Of course, it was quite difficult 14 years ago when we started with the flapless approach because we didn't have the digital guides, and also we needed to have a very good knowledge of the anatomy and the 3D situation of the patient. So of course we used Cbct scans even at that time, but we had to, let's say, use it in a digital way, like we were using our fingers to feel the ridge, and with the one eye looking at the Cbct scan, so we were be able to, let's say, free guide the drills and the implement. So I'm going to show you another case. Of course, we were talking about the safeness of the flapless approach, but since we were doing the extraction in a minimally invasive way using the piezo surgery, so we are using piezo surgery for almost 15 years now. So all the extraction that we were done for preserving the ridge were done atraumatically, and all the time we needed, we used the piezo surgery. So now just let's say straightforward case of the ridge that it was preserved by us. And we are doing the tissue punch. Of course, there are many advantages of the flapless approach in terms of postoperative pain and swelling at the site of the flap elevation. So this is how it looks after we take out the tissue punch. And then we use the concept of biological drilling, which was described by Professor Anitua from Spain. So basically it's a low speed rotation. It's 100 rotations per minute without irrigation. In this scenario, we can also estimate the bone density and also use the autologous bone when we need it from the drills, as you can see in the image. So we were double checking the position. This is a freehand case, position check and tissue level implant insertion. And here you can see the final X-ray after the surgery and after the prosthetic restoration. Now, moving backwards, how we did the extraction. As you can see, at that site, the tooth was fractured. So we had to take out the roots one by one and have this socket preservation called open healing that we are using for almost 14 years. It's a flapless approach of socket preservation. We are fulfilling the gap either with bone granules, usually bios, and cover it with a bioguide and leave it as it is to heal. You are going to see pictures in the next cases. Or when we have all the surrounding walls, we can use the PRGF, the blood clot, and the fibrine membrane. For this case, we used the PRGF and we were able to re-enter after 10 weeks. When we are using the BIOS, we are re-entering after six months. So these are some advantages of the biological approach. But the main important thing of this case was that we were able to do an atraumatic extraction without destroying the septum and the socket walls. And you can see on the right image the Cbct scan 2 years after loading. So this is how the open healing site looks like. So now we move a little bit backwards. As after we did the piezo surgery, a traumatic extraction, and you can see after 10 months how the ridge is looking. It maintained the width, and then we were able to proceed with a flapless implant insertion in a minimal invasive workflow. And the full case after 2 years, there are full zirconia crowns cemented directly on the tissue level implants. And it was the beginning of this full zirconia era. I'm not a very big fan of full zirconia, but this was this case. And you can see at that time they were not able to do all these colors and shades that they are doing now with the full zirconia crowns in the dental laboratory. And again, a 5 years follow-up, you can take a look at the interproximal papilla, and there is a stability around the implant because we were using the concept of Dennis Turner that there are no more than 5 millimeters from the contact point of the papilla to the bone. So this is available also for implants and natural dentition. So here is a close-up with the papillae after 5 years. And the Cbct scan after 5 years as we proceed with our simplicity concept. So piezo for extraction, open healing in terms of socket preservation, flapless approach for implant insertion, biological with concept of prosthetics, and a long-term stability. And again, 2 more years later, 7 years follow-up, you can see it's also a very good stability also on the X-ray and the clinical aspect. Now, some indications about piezo surgery in our everyday practice. I had a lot of discussions with doctors when I was traveling before the pandemic around Europe. Why should we have a piezo surgery machine in our office when we can actually have alternative, even faster treatments with our classical approaches? Okay, I agree, we can do almost everything without piezo surgery, but we have so many advantages, and there are some cases then, for example, when you have let's say a stubborn root that cannot be taken out without fracturing the bone walls, then you just take the piezo, you cut the root out, and then you preserve the bone, and you have no stress in the future steps when placing the implants. So for the advantages that it can offer, I think that there are so many things that we can do, because when we have it in the office, then we really use it. Even sometimes maybe we were able to do a classical approach. So this is our way of doing. We use for extractions, and not only the extractions, piezo surgery whenever needed. And these are the other steps that we do for long-term stability. So we can have a lot of comfort and safety using piezo. It's precise. We don't do any effort. And for the patient, it's very good in terms of post-operative pain. There is no pain and a lot less effort to obtain a cutting line, especially in the bone splitting of narrow crests. So when we do it also in a flapless approach, but this is part of another course. Now, we use it for traumatic extractions. We use it for osteoplasty. We use it a lot for bone splitting. So bone splitting is done, I think, 99% now with piezo surgery, vertical augmentations as well, internal sinus lifting, and also cutting the window for external sinus lifting. And in the last years, we use it for corticotomy in conjunction with our orthodontist. Now, a little bit about patient planning, from backward planning to the final restoration. We always do this work interdisciplinary, and we try to have the final result in mind from the beginning. We have a dedicated session for initial consultation where we do the pictures, 2D and 3D imaging, intraoral scan. We used to do study cast, but we do now just intraoral scan, because we can do a faster digital WhatsApp to let the patient know how it's going to be in the end, and also to be able to prepare the treatment steps. We need to be very fair with the patients in terms of expectations versus reality when we are talking about the teeth in one day or maybe a few more days. So treatments are planning, always having the final result in mind, also with respect to the patient, and also with respect to our team work, as we need to be very precise when we choose the right steps of the treatment plan. And implants always are placed according to the position of the future restoration. Now, since we are using the surgical guides, we have the possibility to use the digital WhatsApp and place the implants in the right position. When we were using the same concept but in an analog way, we observed that we had sometimes some let's say inadequate situations, like a few percents of a millimeter position, different position or things like that. But since we started with digital, we are improving to the, let's say, maximum this strategy. So this is our circle of treatment. Let's say we are starting the treatment with this backward planning concept, such as we have the final prosthetic project, regardless the type of treatment that we are going to do. We are using the open healing extraction site management, and we use piezo surgery always when we need it for preserving the bone around the extraction site, the flapless implant placement, and the biological concept of the prosthetic or rehabilitation. Also, it's very important to monitor the patient and to have a very correct functional checkup also when we finish the treatment, and for all future checkups. This is just a short description and a comparison of the natural dentition with a tissue level implant. So it is biological width that it's respected by the design, the polished neck of the tissue level implant, which we gain also with a bone level implant, but only after we connect the abutment. So this is one of the reasons that we are preferring the tissue level implants, and also the fact that we are not losing bone around the implant after the biological width is established, because the biological width is respected from the beginning. A short comparison between the tissue level implant and the bone level implant in terms of prosthetic parts, such as we will be able to describe it in the next cases. And we have this biological width concept both around implants and natural dentition. So now, how about the treatment approach? How do we create a treatment plan? How do we select our surgical protocol? And how do we choose the prosthetic protocol? Now, is it analog or digital? It's a very, very big fashion with digital today. But honestly, I can tell you that I was pretty much against the digital approach until 3 years ago when we started testing it. And now I am a very big fan of using the digital in our treatment planning and in our surgical protocol, because I realized that it improves our workflow very, very much. So we need, as I said, to be simple, predictable, safe, minimally invasive, and biological in all the things that we are doing for our patients, because this way the patients are going to love us. Now, preserving the 3D architecture. It's a case, an older case, where we had to extract the left upper lateral. This is the X-ray. On the X-ray, actually, it was almost impossible to detect something. It was a tooth that was previously treated with a root canal like 4 years before, and had a small buccal fistula after 4 years. So we made a Cbct scan, and we saw that this patient developed a very, very big size, but in a palatal way. So it increased it so much until we had the possibility to see the buccal fistula. So basically, we had to think carefully about how are we going to treat this case. Of course, we had to think in a minimally invasive way. So we extracted atraumatically the tooth, and we were trying to be as flapless as possible, especially around the papillae and around the buccal region that is going to generate the stability of the 3D architecture. So we just had to cut more apical for taking out the cyst. Of course, we had to clean very well the region, and now we had to decide either to place the implant immediately or to do it in a stage approach. So we decided to fulfill the gap remained after the cyst, and it was too obvious that the papillae and the 3D architecture around the buccal zone of the fixed gingiva that we did not cut will remain the same, especially if we were going to place an implant right away. So this is what we did. We inserted a soft tissue level implant in that position, and this is how the clinical situation ended after the surgery. So all the time it's possible we do not cut the periosteum, because we need to respect the periosteum. We do not cut the papillae, and we do not raise any flap to destroy the anatomical formations of the biological width. This is the clinical situation. So we fulfilled the small gap around the implant with BIOS and cyanoacrylate that we fulfill the gaps, and we stick the provisional. The provisional was prepared before. This is an older case. Now we do the provisionals from with another material, and we glue them adhesive. We use rubber dam not to have problems with the surrounding region around the implant. So this is the before surgery situation and after surgery when the patient left with a provisional. Of course, here we have the situation of the emergence profile of the neighboring teeth that are not going to be very supportive for our future prosthetic crown on the implant, but as the patient did not want to complete the treatment with veneers for modifying the emergence profile for supporting the papilla, we agreed that we might lose some of the gingival level in the future. So this is the healing, the provisional after we placed the abutment on the lateral, and now with a definitive restoration after cementation after 2 years and after 5 years. You can see that especially the fixed gingiva around the implant is very stable. Of course, we lost some of the gingival height, but it was not only near the implant, it's a general situation because the patient is aging and she didn't want to do anything in this regard. And after 7 years, and here is a close-up after 7 years, such as you can see that the fixed gingiva that we did not touch, did not cut, remained very stable. Here is the CBCT before surgery, then after 5 years with the crown cemented, and again 2 more years. Remember that we just did everything in only one session and we did not raise any flap. It was the atraumatic extraction and the cleaning of the sides that was developed at that time. And again, after 9 years, you can see that everything is very stable. Now, there are many things about the periosteum, but what I can say is that as we protect the periosteum, even we have a very, very thin buccal bone layer around the implant, it's going to be there. Otherwise, if we just take the periosteum out and we do raise a flap, then it's going to be a bye-bye bone party for that thin bone. Now, why it's very important to have a very simple and safe approach when we are extracting teeth. It's very important to use, when we use the piezo surgery, we can cut the roots, we can protect the septum, we can protect the buccal bone, even it's very thin. So we are able even to place implants when we have the right septum in type A situations in the lateral zone. The lateral zone immediate implant placement is something that is not very all the time possible, but in type A, when the septum is present and it's a good diameter of the septum, and type B, where there is some septum and we need to fulfill the rest of the gap, we do immediate implant placement even in the lateral zone, considering that we are doing the extraction in the right minimal invasive way. And of course, when there is no septal bone or when we don't get a primary stability, then we don't do it. So here is a case where we extracted atraumatically the tooth, and we have a very generous septum present. Also, this case is older, so it's from the time before the digital protocol appeared in our office. We extracted the tooth, we inserted the initial drill in the septum, and then we condensed the bone at that level to the diameter of the future implant. Before going with the osteotomes, we fulfilled partially the the alveoli, such as in case of fracture of the septum, when we used the mechanical osteotomes, we had at least the mechanical stability of the fracture septum. So it was not the case here. We were able to enlarge it with the osteotomes and then insert the implant. After we inserted the implant, we fulfilled the rest of the gap with BIOS. And as you can see, there is no flap raised. So we just covered the socket as in our open healing concept. We covered the socket with a BioGuide and then a continuous suture and the healing, the open healing after post-extraction implant. We always use the PTFE suture because its properties, and you can see after 3 weeks, it's visible the neck of the tissue level implant, and there is also already the secondary granulation around this implant. And this is the Cbct scan. Of course, you can see that was a very good situation of immediate implant placement. And you can see how we were able to place the implant right in the septum. And you can see also the BIOS that is in the alveoli. So this is 1 year clinical follow-up and an X-ray. Of course, we had to do the microscope root canal of neighboring teeth. It's a 3 years follow-up. Again, it is very stable. 5 years follow-up. There is no modification. And a 7 years follow-up. It's very nice when we have follow-up with good condition after so many years, and that is why we trust our approach and concept. So, when possible, just don't flap and protect the periosteum, as it is a key factor in regenerating the new bone and protecting the existing bone. So, once again, to show you how the ridges looks like after we extract in a minimally invasive way using the piezo surgery, and how we are able to place in a flapless manner the implants in that ridges. So this is another case for 10 years ago. You can see the ridge was very well preserved. It was again the open healing concept with a BIOS and BioGuide. And here is the insertion of the implant in a flapless manner as I showed before. And just for comparison, a newer case that we did 2 years ago in the same site, in the same type of situation after an open healing concept, and also after piezo surgery at traumatic extraction. And this time we were using the surgical guide for implant positioning. So you can see the comparison when we did it freehand and then when we did it in a digital approach. Also a tissue level implant with a very good stability, because we were able to preserve the crest in terms of width, height, and bone density using these atraumatic extractions and the open healing concept. This is the key of the success of the future minimally invasive flapless implant placement. So again, a comparison between the freehand and the guided. You can see that we placed in both situations, we placed the implant right in the septum position. Imagine if we were not able to preserve the septum, it was even more difficult to have a native bone in that region. It would have been just BIOS, and for also integration and stability, it's better this way. And that is why I encourage this, let's say, not very fast, minimally invasive extraction. Even when we need it, we use the piezo surgery to protect the surrounding bone, as I said. And the final case, the digital one. and a follow-up of the old case, how it looked in 2011 and how nice it looks after 8 years in 2019. You can see the papillae and how the crown is there. And again, the Cbct scan and the position of the free-handed placed implant in the septum. It's very tricky when you place it flapless freehand in this situation in the septum, because it can easily lose the position of the drill, because it's a different density where you have bios, and it's a different density, of course, where you have the septum. And if the bios, it's not, let's say after at least 6 months, it can be a little bit softer than the native bone, and then the drill can slip into the old alveolar, and then you cannot have the right position. While when using the digital concept, then you can just go correctly in the right position. But this is how we did it 8 years ago, and this is how we do it now with the digital world. Again, about immediate versus delayed. So we do the extraction, we preserve the bone, but when are we inserting the implant? So there are some ideas how we came to the open healing concept. So we developed a technique that it was called ice cream cone technique by Dennis Turner into this open healing together with Dr. Taffet from Germany. And now we were publishing the new results after the open healing concept. It's a little bit modified, that we are using the PTFE continuous suture above the membrane. So we are not we are not suturing the membrane to the gingiva, free gingival margin, how Dennis Turner did it. And this is a comparison sketch. So where is possible, we insert the implant. And if needed, we place the membrane and the bone granules to fulfill the gap, and we do not flap. We just cover by the membrane and do the continuous suture. While when it's not possible, because we either don't get the primary stability, or we have a very severe resorption of the buccal bone, after we do the atraumatic extraction with the Piezo surgery, we just insert the membrane deep into the alveolar, and then we fulfill the gap with the bios, and then you can see we do the suture without doing any flap. So this is a clinical case where we did a traumatic extraction, and we had no buccal bone. So we had to insert the membrane very deep, and then we put the bios granules in a very thin syringe, and we were pressing the granules to fix the membrane apically. Then we turned the membrane to the palate, and we did the continuous suture with a PTFE suture. This is the provisional. We used the old crown, we cut out the root, and here is how it looks after 6 months. Of course, we had to renew the crown on the other central incisor, such as we will be able to use the 5mm concept from the contact point to the papilla, and also to have a better aesthetic result. But the implant was inserted flapless, freehand flapless, in a 3D position that is going to respect the future position of the crown. And this is after 6 more months when we did the restoration. The crowns on the tissue level implants in the aesthetic zone are cemented, and you can see it's a similar approach to the natural dentition. So we cement the crowns and we respect the 5mm distance from the contact points to the papilla, from the implant to the neighboring teeth, and also from the natural dentition to the neighboring dentition. So this is the evolution. We call the patient every year for follow-ups, and this patient is very addicted to sports, and he's doing some, let's say, forbidden things with his sports partners sometimes, and this is how he lost and fractured the first incisor. This is close-up with the connection of the crown cemented directly on the implant, and you can see how nice the 3D architecture was preserved. But surprise, in 2018, again after his sports contacts, he had another fracture. Fortunately for our case, he did it in the other central incisor, where we were able to place the implant immediately after the atraumatic extraction. And this is the sequence of the healing and how it looked. On the Cbct scan, you can see on the left side image is the initial situation and the follow-ups of the right upper central incisor, and on the left side is the immediate implant placed left upper central incisor. So this is the restoration. Something looks wrong. After we cemented, I came to my colleague who is doing the prosthetics. I saw the patient, I took the pictures, and I said, this is just immediate in the same day with the cementation. That is why the gingiva is a little bit irritated. And I said, look, I don't like it. What's going on? And then I convinced the patient to take out the cemented crown and do a digital, let's say, copy, paste, and reverse of the other crown, and decide to fulfill the gap on the lateral incisor with a non-prep veneer. And now, with the digital help, we were able to redo the case in an even nicer aesthetic approach. So this is how we did it in the end, and you can see a comparison of the one crown is with layered ceramic on the zirconia, and the other one, as we just copied it, it's a full zirconia crown with this new generation of monolithic zirconia that you can stain them and look like very natural, as you can see. Now, about piezosurgery extraction, there are some advantages that are here. So we reduce the need of surgical flaps, which is very good for our approach. No alveolotomy necessary, because we just cut with the piezo exactly where we need, and we maintain the integrity of the alveolar bone. And it's very, very mild to the surrounding areas and to the bone. It's less as aggressive than burrs. And also there is a minimal force that is required for extraction, and then this limits the risk of damage to the adjacent piece. There are some very nice articles published with the use of piezotome versus the classical extraction that I recommend to take a look on them. And if you want, I can you can just write me an email and I can send you some bibliography to read about this. And just a short description of the piezosurgery extraction. So we use the extraction tip and then cut out the root, and then the root is just going out with very, very easily from the alveolar lichen avulsion in this case. So it's very easy and it's very predictable, especially in the aesthetic zone where we have like 0.3 millimeters of buccal bone. We use a flapless approach, and we do not want to ruin that bone in an ankylosing root. And here is another case, a similar case, where we had the same protocol with the membrane the open healing, the provisional. You can see the provisional, it's different now that we did it from a different material and in a digital way. And we observed that this time our problem was it was not the right width of the crest. So in this case, we have two alternatives in the implant stage. Either we do a supplementary augmentation, either bone augmentation or soft tissue augmentation, or we can just use a split concept and we are enlarging the crest from the inside. And you can see here the original sketch of this concept. It was described with manual osteotomes. So you go with the first pair and then you can enlarge it and you have an improved width of the crest. No need to place a narrower implant that will ruin the aesthetics in this case. So what we tried to do to mix the digital approach with our flapless bone spreading, bone splitting with Piezotome-Surgery. And we used the guide for the initial drill. Then we used through the guide the full sequence of the Piezotome-Surgery to enlarge the bone as much as possible. Then we used also the old-fashioned manual osteotome for the final diameter of the implant because it was already cut, the bone was already cut by the piezo. And this is how we enlarge the crest and place the flapless implant. Of course, we can do any buccal surgery anytime because we never ever raised a flap in that region, so we never cut the periosteum, we never cut the fixed gingiva, there is no scar there. So if we will ever have the need of improving this situation, we can do it as we did it before doing any surgery because we never cut this this region. So you can see how it looks. It is a significant improvement, not the perfect one, but a significant improvement for this minimally invasive approach. And here is a mock-up and the trying. Of course, for this case, we did veneers as well for the other teeth. And here you can see Cbct scan before treatment with and after the open healing and after the implant placement. You can see the marginal bone is up to the polished neck of the implant. And after we split it, and being flapless, we had no risk of having this buccal cortical diminish. These are how we do the color. And after cementation, you can see a slight irritation of the gingiva, and this is how it looks after 1 year. You can see that everything is very nice and stable. It's how the patient came and how we ended up with the treatment, of course, with the digital support in this situation. Okay, one more case from analog to digital, an older patient with this situation that became painful for him. We decided to do the extraction, and in order to avoid a future sinus lifting, we decided to preserve the vertical height of the crest, combining the open healing concept, the atraumatic extractions, of course, but here it was a very poor implantation of the teeth anyway. And in a, let's say, flapless manner, because we only took out, raised like 1.52 millimeters of the gingiva on the bone just to place the pins for this titanium mesh. and conjunction of titanium mesh with BIOS and BioGuide and the open healing concept. And this is how the crest is healing after 2 days, 7 days, and 3 weeks. And then we decided to leave the titanium mesh there for 6 months. Of course, if the titanium mesh is moving during this period, you need to take it out because it's affecting the healing. So this is where we started and the situation after the surgery. Then after 6 months, we removed the titanium mesh, flapless implant insertion of tissue level implants, and the final prosthetics in situ. You can see how nice we preserved. Otherwise, just extracting with no preserving of the crest in a vertical side as well, it would have been external sinus lift and a very big difference between the distal bone of the last remaining tooth to the first implant. Now, this is a situation after cementation, then 2 years. It's a Cbct scan on the right image that is why it looks like this. But on the Cbct, you can see that everything is very fixed, fast, and stable. Here again in 2017, it's 3 years. It's very nice that we have a fixed gingiva and we did not need any additional surgery for fixed gingiva. Again, 5 more years. You can now compare the same type of X-ray that we did it in the first place. You can see that the level of the bone is very nice and stable. So this is the evolution. So first is a retroalveolar X-ray. The second and the third are taken from the second is from the Cbct scan. The third is from the panoramic X-ray, and the third is again of retroalveolar. And now one more year after this situation, it was a problem with the neighboring tooth. So due to the situation, we had to extract it again with a piezo surgery, and we inserted the first ever tissue level implant that was designed with no abutment. So there is a special tissue level implant called Matrix, produced in Switzerland. You can see it looks like a tissue level implant, but it has a special connection that will allow the insertion of the crown directly to the implant with no abutment, no cementation, nothing. So this is the implant insertion, fulfilling the gap, palatal with a cyanoacrylate and buccal with a BIOS and BioGuide in our classical ready open healing concept. This is the healing, the standard abutment versus a customized healing abutment. We scanned immediately before the surgery and immediately after the surgery, such as we used the design of the natural dentition to generate customized healing abutment with the exact emergence profile of his natural dentition, which is very nice nowadays to use it like this. And this is the Cbct scan with the implant after the insertion. It was a digitally guided, and you can see the right angulation for the future crown of this special implant. This is how it looks with a customized healing abutment, and this is how nice it healed with this customized healing abutment. And you can see this is the final restoration after 4 months, and you can see on the X-ray how the crown is screwed directly to the tissue level implant, and you can compare it with the crown that was cemented to the other tissue level implant, the old one that we used at that initial case. And this is how the connection looked like. This is the final restoration on the on the digital way, and this is the final situation that we had in the clinical aspect. Now, there are some advantages of the tissue level implants. I'm not going to go through this because I think we are running a little bit out of time, and I'm going to go straight to the last case, or the last two cases, with a digital approach that we are using now, and it helps a lot for our prosthetic parts, but also very important that we preserve the ridge with a nice atraumatic extraction concept, because you can see in this case the patient came to us with a tooth already extracted, and you can see that the crest is quite narrow, and we had to do some mixed bone spreading and in order to be able to solve the case in a minimally invasive way. But it's very important to have the right position of the implant, regardless the bone. We need to do it connected to the concept of the future prosthetic. And this is the before picture and after the bone spreading that we did here. And you can see if we had a nice open healing concept in this case, we would have much nicer and larger ridge. And this is how it looks in the clinical aspect. And the armamentarium that used with Piezotome-Surgery. And this you can see on the last page. You can see the bone, the buccal bone. And this is the case when we did the final prosthetics in a digital way as well. As I said, I was not a big fan of digital before, but now I started to like it very much. It's very precise, but I will not recommend anyone to start digital without knowing the right, or to have the right background for the anatomy, either for surgery or for prosthetics, or mixing the both. And this is the stability of the implant with the ostel measure, and this is the screw retained crown this time as the final result, and the x-ray of the screw retained crown. So there is one more case. Do we have time for this, or we go just straight to the question and answer, Jarjan? It's
yes, we can also, we have time for this case.
Okay. One more case that we did, and we mixed the digital approach with the Piezotome-Surgery. It's a case that we did before the pandemic. The patient came from Germany with this narrow crest. He's a doctor in Germany. And we said, okay, we are trying to do something. We hope that we will not have a new world rule with this pandemic. And unfortunately, we now have a new world rule with this pandemic, but this was a discussion in March, just right before the lockdown that we had. So we analyzed, and of course, we were able to do surgical guide, but in this case, with narrow crests, we have the surgical guides for the implant positioning, but we do the bone splitting before, because otherwise, if we just go with a burst through the guide before the splitting, it's going to go outside the crest, because the crest is still too narrow. So you can see the planning, bone splitting in the premolar and the internal sinus lid in the molar region. And this is our surgical guide. And this is how we marked the zones through the guide. And then we proceed with a minimally invasive bone split. It's very, very difficult when you do it in such a narrow crest, when you only have for one implant the space. And you can see the other one, it went straight forward with the internal sinus lifting. And you can see the buccal place, how we move it more buccally, and then we used the surgical guide for the implant positioning. And then we sutured, and you can see it's just a crestal incision, and we covered the gap with the bioguide as usual, and we did not intend to close with tension. So it's like in the open healing concept. So you can see the CBCT after treatment, and there is a very nice but thin crest. And 6 months after the patient was able again to travel, and you can see the difference from the initial situation to the existing situation. And also you can see how stable looks even for the narrow bone splitting that we did for this case. Then we designed prosthetics also in a digital way. And this is the design, very similar with what we did before treatment. I mean, it was a copy of the initial situation. Here is a digital mock-up. We printed the first version of the crowns, and then we milled the final version of the crown. We have some ceramic that was put on the buccal part for mimicking the aesthetic better. And this is the final clinical situation. And here is the X-ray after we screw retained the crown for this case. So my conclusion for today is we need to be minimally invasive. We need to use our brain, not let the machines think instead of us. But we can always use our help of the digital apparatus to support our techniques. But before that, we need to think biological, to do the extraction as atraumatic as possible. And as you saw, with all these cases, we had these piezo surgery approaches. And our keywords, after 14 years of biological guided approach, we were minimally invasive, flapless in terms of implant placement, open healing concept for solid preservation. We always use tissue level implants because of the biological advantages, and we generate comfort to the patients and to our team. Here is my email address, and if you ever want to get more information, or you have a case that you want to do it in a minimally invasive way and we want to discuss about it, we can you can anytime use the email address. It's my private email address. You can send any ideas or questions. Thank you very much for your attention, and I hope you enjoyed. I saw that we had this webinar. Now we are probably preparing a second one sometime soon for the second part of this minimally invasive approach with the piezo surgery, but we will let you know in time. Thank you very much.